Brian, you were mentioning they pulled out of the vault a 30-year-old video of you. What did the younger version of Dr. Brian Mishara have to say?
Well, I was surprised because things haven't changed all that much in 30 years. You know, when grad students they're doing their thesis, try to do literature reviews, go back 10 years as if anything over 10 years is useless. So I think that there's a lot of reinventing the wheel because we don't want to look at the older stuff where there were great insights in the past. And I'm not saying they came from me necessarily, but when you're talking about things like why people kill themselves, I don't think we've had a whole lot of earth-shaking discovery since then.
Yeah. Well, John, this is great stuff. This is an opportunity. You and I are not young, but we're going to go into the vault today.
Yeah, and actually, Brian, I was just thinking that I would love to see that because I imagine that you were probably young and cantankerous too.
Yeah, a little more cantankerous when I was young. All
right, well, you've mellowed in age. Beautiful.
Let's get after it today.
Welcome aboard Lifelines with David and John, your guide to charting the transformative course of crisis intervention and the game-changing 988 Lifeline.
Well, hey there, everyone, and welcome back to the 988 Lifelines Podcast with David and John, where every call is a fresh start. And we're coming to you, Brian, we're coming straight from the heart of Atlanta, where Behavioral Health Link is headquartered, all the way to Montreal and around the world. We're ripping across the nation, diving deep into the heartbeat of crisis intervention every week. We're talking about the rich history of crisis care, but also unpacking the electrifying future of 988. I'm David Covington, and I'm alongside my partner, Dr. John Draper, crisis experienced, and have been working in this effort for many decades. So you can watch us on YouTube. Please like and subscribe or listen to us wherever you get your podcasts. Today, the show is brought to us by Behavioral Health Link. It's our 15th episode. And I'm thrilled to hear from Dr. Brian Mishara. Brooklyn, why don't you tell us a little bit about our guest today?
It's so good to have my old friend, Dr. Brian Mishara, with us today, an internationally acclaimed researcher and trainer in suicide prevention. Brian's published now 8 books and over 170 peer-reviewed articles, with my favorites being his many groundbreaking findings and helpline practices. And Brian's a professor of psychology and the director of the Center for Research and Intervention in Suicide at the University of Québec in Montreal. And I got to say, David, that Brian's work has been instrumental in shaping policies and programs that have saved countless lives, not only in North America, but across the globe. Great to have you, Brian.
Great to be here.
John, it was
distinguished hosts.
I believe, John, it was late December of it would have been 2004 when the seminal group was coming to Chokecherry out in Rockville, and Brian and John Califat and Maddie Gould all presented.
2005. It was at the AS conference in Colorado in 2005. Yeah.
No, but there was a meeting at SAMHSA where they presented their preliminary findings. It's the first time I heard Brian talk about the individual who suggested the caller simply kill themselves.
Yeah, there were very few of them, but we heard a few of those. They were strange situations, but
yeah,
you know.
So Brian, before we get into the mix, we want to learn a little bit about you. Can you tell us something, maybe a personal interest or something about you that John and I might not know?
Well, I never intended to study suicide or anything like that. I was originally studying the psychology of the arts, and I did a master's thesis on studies of cognitive style and appreciation of paintings and understanding of paintings.
Wow.
And I directed an experimental theater company, an alternative company in Ann Arbor, Michigan, and I was going to make films and study psychology of the arts. But my thesis instructor went on sabbatical and came back after a year of studying Zen Buddhism and just refused to open his mouth and talk to people about anything to do with psychology. So I wound up having to find a new thesis director and wound up being have more of a clinical focus. And Bob Kastenbaum, who wrote the classic book, The Psychology of Death, in umpteen editions, arrived, and he was the only one that had no grad students. So I said, okay, I'll do something with him. And
Sure.
I got a full-time job working in a mental hospital with the elderly, and started doing some research, and eventually just focused in gerontology. I was studying aging. I wrote a classic book, I think, in French called Vieillissement, Human Aging or Aging, published by the French Université Press. And I was studying that. And then there was one of my students said, we want to start a helpline in Montreal. We're meeting a group of people to talk about it. You want to come? You know something about death and dying? And I said, sure. I started coming. And then I wound up to be president of the board and one of the first trainers and volunteers and all that. But we couldn't get funding from the government because they said there wasn't evidence that helplines really help suicidal people. So I started doing some research on the effectiveness of helplines in order to help them get some funding. And then little by little, my aging research sort of dropped off, and I just focused more on suicide, but there was no master plan.
Wow. That really fills in some gaps for me, John.
No kidding. Most of that I've not heard before, Brian.
Yeah.
So it really is something I didn't know about you.
So, Brian, the other thing we do to start is we have a little thing where John and I try to guess what you're a super fan of. And I usually, sneak around the person's Facebook page, which I couldn't find one for you.
Oh, I don't have one.
So this is total guesswork. And John, so I'm a super fan we're going to Amsterdam to visit 113. I'm a super fan of, Brian mentioned art, the Night's Watch, the Rembrandt piece at the museum in Amsterdam I am a super fan of that piece of art. John, what are you a super fan of?
Well, I'm a super fan of riding bikes, and I'm going to go to Amsterdam, and I'm going to do that for sure.
Okay, so let's just without, we know about Brian. I thought I knew Brian well until I couldn't get his Facebook page and, his personal interest. But I'm going to just write on a piece of paper. John, let's just write down what we think is Brian's a super fan of. And Brian, you have to say if there's a winner or there's not a winner because we're so. Okay. John, I have got mine.
All right.
What do you think Brian is a super fan of?
All right.
Go ahead. Photography is a good one. I'm going to say he's a super fan of international travel.
That just took you 3 seconds to do that, David?
So, Brian, international travel or photography, is either one of us even warm?
Well, I grew up working in a camera store, and I worked as a professional wedding photographer when I was a teenager. And it's one of my, that and cinematography. My daughter's a professional cinematographer now, but it's something I grew up in. I also, for a short period of time, owned a camera store in Boston and commuted there from Montreal. Craziest thing I did for 3 years. But I am very much into photography. And I don't know if I'm a fan of international travel. I like what I do internationally.
Right.
But the travel part of it, I could do without. I'd like one of those, just press the button and you're beamed there. Would be a lot easier, though. I've gotten used to that.
Well, Brian, we are so glad you're on the program today, and we'll have some little pictures that we put into this podcast. Would love to see that 30-year-old version. Did you capture Did you capture that video?
I didn't get it. It's in French. It might be fun to see, but
it might be fun to see.
Yeah.
So, John, before we get rolling today, why don't you tell us about our sponsor, Behavioral Health Link, which is bringing us Dr. Brian Mishara today?
Yes, and David, it's an honor to have my friend and colleague Brian Mishara with us, whose research was central to reminding us that crisis helplines are most helpful when counselors are listening with understanding to callers and actively collaborating with them to solve problems. So these principles guided us in creating BHL's call center platform, which is designed to put the relationship between the counselor and caller first. It makes required data collection intuitive, allowing the counselor to seamlessly click on items while listening, engaging, assessing, and collaborating with the caller. The platform is fully 98 ready and has evidence-based practices built into its DNA. It's also designed to evolve as BHL and its crisis care partners continue to innovate, research, and extend our services in new ways over the coming years. So for more information on the BHL call center platform, just check out behavioralhealthlink.com. David?
Thank you, John, and thanks to our sponsor. Our next segment is the good news, John, and there's constantly some new news. Things, the more things change, the more they're just the same. Brian was talking about some of that history. But there's some developments here that I'd like to touch base on. I had the opportunity, John, Brian, to go to a launch of the Mental Health PAC, one of these political action committees that's been formed by Inseparable. And I was meeting with their leadership, talked to Angela Kimball, one of the former leaders of NAMI, and she was telling me about this report that was just released by Inseparable last week, John. Someone to talk to, someone to respond, a safe place for help. Their analysis of policy change by state, and they've done a state-by-state review. I mean, it's one of those things you got to model, and it is what it is. I think they're probably going to score Arizona and Georgia not well because of the lack of some of that policy movement, even though both those states spend $350 million in a core crisis continuum. But it's a place to start a conversation.
Absolutely.
I think Washington State, they talk about that their Representative Tina Orwell and others have led some amazing legislative actions, but very little has happened at the provider level to follow up on those visions. So, John, any reflections on the better response paper and the work Inseparable is doing around a reform crisis system?
Well, I love the fact that Inseparable is really kind of forcing the question of accountability, which Brian knows very well. We need to have data to hold crisis systems accountable. So we're continuously in the process of analyzing ourselves for improvement. This helps us do that. I think I had some concerns about the snapshot of how it described where states are right now. And I'm not sure where they got that data from in some cases. And it was just a snapshot. It doesn't mean how they were a few months ago or even, last week. But as you say, it's a great place to begin a conversation around accountability.
Yeah, I think it's, around specifically the introduction of the standardized legislation or the proposed legislation of surcharge for 988 fee, et cetera. The other thing is, and Brian's already leaned into this, the history. Brian, one of my most favorite things in my career has been mentoring under Dr. Michael Hogan. And it's been several times that I've been launching some new, what I thought was an innovative initiative. And he'll always say, well, so-and-so did that 10 years ago, and this other guy did it 15 years ago, and 25 years ago, this other person tried that. And it's humbling. And also there's a lot of history out there. And John, you and Richard just published a paper on the historical perspective of crisis hotlines. Tell us about this journey.
Oh, this was really fun to do. And I know this is a passion of yours, Brian, is asking the question, not only where are we now, but where did all this come from? And not forgetting the lessons that we should be learning from the past. And again, looking back at where hotlines were and where they are now and drawing those threads are not only important in seeing where we've come, but also how we haven't changed in some really important ways. And also, what are some of the challenges for the future? So all of that is in this, and I'm looking forward to people having an opportunity to read it.
I'd love to read it. I've been interested in going back before actual systematic helplines, how people started providing help without having it under the guise of some professional psychotherapy. And, probably the first suicide prevention center was Salvation Army in New York.
Like in the 20s or something.
No,
right?
or before then.
Before that. Oh, the turn of the century.
1910, New York Times had an article on how people came, told their problems, and they felt better and didn't go ahead and kill themselves. But they focused a lot on actual concrete help, like giving people jobs, a place to live, food, and things like that. So it wasn't just a talk situation, but they felt that people needed concrete help as well. There were even some attempts in Vienna in the 1930s to start a psychoanalysis helpline.
Right.
Well, it wasn't really a helpline. It was psychoanalysis using the new technology of the telephone.
Yeah.
And somehow, the psychiatric psychoanalytic center in Vienna tried this, and it didn't quite work. So for some reason, they did abandon that idea. But the history of the what I think is how the first helpline in the UK started with Chad Vera.
Yeah.
I mean,
Really important stuff.
Yeah, I mean, he was doing therapy, and people were lined up waiting to see him in this church where he was giving free therapy, and people started coming at the time of their appointment saying, I don't need to talk to you now, I'm feeling okay, and said something strange is going on. They were telling their problems to the everyday people who were making the tea and taking the appointments, and they were feeling better, and they didn't need the therapy, and that gave him the idea that, there's just one of him, and there's so many people who have the ability to listen to other people's problems and be helpful, and he started Samaritans based on that experience.
Vicar Vera was he was kind of the first to realize that, hey, I thought it was just us professionals that really know how to help people, but no, it's actually, we need to arm everyone with the ability to provide, like the Salvation Army, salvation to others.
Yeah, well actually, the empirical research shows that non-professionals in every published study, except for one, and that's one I did, found that volunteers or non-professionals do a better job on helplines than training, and the more diplomas you have, the less good job you do. The study I did found no difference, but that was because the professionals got a good dose of volunteer training.
But Brian, I'm going to talk all about that in Plain Truth. So hold on to that thought. We'll definitely be talking about that soon.
Okay, because it's not the way we're going. It's becoming more.
That's what I'm talking about for sure. Yeah.
So, John, you laid out some of the context and history, and Brian's fleshing that in from New York to Vienna to the United Kingdom. Where are we going now, John? Talk about a little bit of the future.
I mean, again, that article is about, the U.S. history and of hotlines and how it led to 988. And now Canada is starting 988. Brian, and you are very much involved with a lot of the work, the seminal work with crisis hotlines here in the United States, and you have been in Canada too, that really led to our 988 here. Tell us about how it's looking in terms of Canada's 988. How is it different than what we're doing in the United States?
Well, I mean, it's starting out as it did in the States, of getting existing centers to sign on and link without the big infrastructure of providing specific models and training and the big budgets of the U.S. So time will tell how things develop as it rolls out and gets funded and so forth. There's been no external evaluations as yet of the system, and we have our own unique situations. For example, in Quebec, they refuse to use 988, but it exists. And if you dial it, you'll get into the Quebec system, which has their own number, but they really don't want to have anything particular to do with it because they think they're doing a better job. And the 988 people tried to get them to sort of go along with some of their ideas, and they said, you should go along with our ideas. And here's the two solitudes of French and English Canada playing out in this little microcosm of 988. But, it's just starting up. It's getting together. They've done a phenomenal job of just getting it working, functionally working. And we'll see how things develop over time.
Brian, I'm wondering what lessons are there as you have worked with crisis call lines around the world? We were talking about 113 in Amsterdam earlier, but you've been to a number of locations around the globe. What should we be learning from others, or what are they doing in Canada or the U.S. that should be going the other way?
Well, I think there's a couple of things. One thing is that I used to think when I was doing my earlier research that that's all you have to do is find the truth, and then you show it to people, and then they'll say, wow, I'll do a better job. There's some proof. This is what you're supposed to do. Or they go do some better research and find some proof that something else is better.
Right.
I thought that's the way of the world. But the reality is that most services and the way they're delivered and how calls are handled is based upon views of individuals who have some power to influence what's going on. Now, when you have a John Draper as the head of Lifeline, who is into research and open to research and reads it and understands it and tries to have practices follow what people think should be done and into evaluation, that's the exception. The rule is that people do pretty much what their founder set out, and it takes an earthquake to budge it a little bit. And I was just having a conversation with a educated helpline director in North America, and I was saying, but research clearly shows, and she just interrupted me and she said, oh, that's just research. And then she told me what they did. And, I think that a lot of practices evolve based upon, it seems to be working, gut feelings, the dynamics of local things, financing and other things. And that's too bad because it stifles creativity. And, I think one of the biggest problems in helplines is that we're standardizing more and more. And the computer systems are helping with this because they tell you ask this, then that. And now with AI, we get prompts. Why don't you say this and say that? So that we'll, or might you explore this now? There's a key word, or that person's anxiety is going up. I've been monitoring their voice tone. We're actually doing studies on these sorts of things right now and assessing usefulness of giving feedback of changes in emotions as monitored in the tone of voice. And we just published a paper on that. But but what the downside is that the creativity of just helping someone in an innovative way or is going out the window. And the other thing is that people think still that it's what you say or what questions you ask that matters in these life and death situations with someone who's suicidal, when what really matters is who you are whether the person feels you're wrong, whether they feel they care, and that you're with them, and that you support them. And, you know, people, it's so much easier to say, if I do this, that, and the other thing, everything's going to work, and I did my job, and everything's okay, than to be yourself and trust yourself. And we are all different. And my style of helping the same person would be different from John or David's style with the same person, because we have our own experience, own way of dealing with things, and what we can do and how effective that is doesn't have to do with what we're doing so much as how we're doing it, who we are, how empathetic we really are, and how much we show that we care about them. You know, one of my experiences, I've done a lot of training, and I've helped start some helplines. Most recently, I helped start a helpline in Barbados, and in Kenya doing some training very recently. And I missed my point here. I was going to say something really brilliant. But,
well, I think the thread, Brian, is this caring engagement, this thoughtful human connection.
Not what you say, but who you are.
Well, what I was going to say was, when I worked in Africa with people who work in refugee camps, I've done some workshops at training programs for people who work in refugee camps, and they're usually full of people, and it's on suicide prevention. Every single time I've done this workshop, the same thing happens within 3 minutes. Someone interrupts me before I even start the workshop, and they basically say the same thing. They tell me a story. I have a man in my camp in Tanzania who comes from Sudan. He witnessed his wife and children tortured to death. He's lost his family. He's lost his job. He's been 5 years in this camp in a foreign country. He'll never be able to go home. He knows there's no more family, no more job. If I was in that situation, I'd want to kill myself. How can you talk about suicide prevention with someone like him? And for me, the answer is just so obvious and simple. This is a very powerful, resourceful man.
Yeah.
He has survived all that.
Yeah.
He's still alive.
Yeah.
He has tremendous resources that have allowed him to keep on living despite that, and to tolerate those 5 years in this camp. And your job in suicide prevention is first to stop seeing him as someone who'd be better off dead, but to see him as he really is, as a person who has incredible resources that has permitted him to go on. And relate to him as if he has those capacities, and then work to identify what are the things that has kept him going and try to reinforce and strengthen them. And then we can get into the workshop. But I think far too often we don't see, we see our clients as poor you. The people who are calling as, they're in trouble, or if we've had a lot of psychology or psychiatry education, we see them in terms of diagnoses.
Yeah, of course.
And once you start doing that, you're missing what suicide prevention is about, which is building on the strength that the person has in their own resources.
So Brian, this concern about people in unbearable pain and this feeling is certainly part of this shift to making sure that countries, states are able to attend to people in unbearable pain. So let's switch to a discussion of this emerging issue of physician-assisted suicide, what is now called medical assistance in dying. And John, I have a trivia question for us to start, an over-under, if you will. John, if we look at a combination of the states in the United States and the countries that have legalized in some shape or form physician assistant. It's usually under certain conditions and has time frames and other things. But that if we add the states in the U.S. and the countries in the world, we add those two numbers together, how many of those have legalized medical assistance in dying? For example, not included in that list is the District of Columbia, which has now done that. So, John, add them up, the states and the countries. What do we believe that number is?
Oh, boy. Brian is going to know this right on the nose, and I don't. But I wasn't even aware of D.C. Certainly aware of Oregon. I don't know where else in the United States.
Oregon is one of those seminal U.S. states. I'll just key in here following, the lead. I don't know if it was the first, but certainly someone who has led
Oregon was the first in the U.S.
Yeah.
But the Netherlands, was the Netherlands the one? I know it's been very influential. I don't know if it was first.
Netherlands was the first to legalize.
Well, the Netherlands is the other one that I'm aware of. And so as far as I know, and if you can't, I don't know if you're counting DC as a state, but it's
I'm not.
All right. So I would say and then Canada, 3. Those are the 3 that I'm fully aware of. But I must be missing a couple, but I don't know what they are. I'm just going to round it to 5, and Brian's going to correct me.
So, Brian, over or under? Is it more or less states?
Quite a few more.
Quite a few more. So, again, look, I'm not the expert that Dr. Mishara is, but ChatGPT, which I pressed a few times, are you sure this is all of them? This is what it shares. California, Colorado,
too. I didn't know them.
Hawaii, Maine, Montana, New Mexico, New Jersey.
I'm just going to see if there's anyone. There's some, let's see. Colombia's in there. Okay. Germany's in there. Luxembourg. I think that's pretty much it. It looks pretty good. I think we're missing one state, and I would try to think of which one it is, because I think there's 11 now. But there are many others that are considering it, and so it is expanding. So I've got a trivia question for you two.
Yeah, bring it, Brian.
What is the country which has or state? What is the geographic place which has the highest proportion of their deaths by medical assistance in dying?
The nation that you're from, Brian.
Yeah.
It's Canada.
Yeah, Canada. We now we have more people die by medical assistance in dying, which is usually euthanasia. Euthanasia, where a doctor gives you a lethal injection, usually, and assisted suicide, which is the only practice legal in the U.S. states, where a physician prescribes a poison, something that you could take, a combination actually, which you can take yourself, and that's why it's called assisted suicide. The assistance is providing the means, but you actually do it yourself. And Switzerland only has assisted suicide legalized, but it actually was never legalized. Just someone figured out that it was never made illegal in that country, so they started practicing it, and no one changed things. They just made a few little laws.
Got it. So Brian, that's a great trivia question, but I wonder to some degree the way that this is protocolized out, it differs dramatically from the Netherlands to some of the states. Did Canada make the right move on this from your vantage point? And
well,
if not,
I mean,
what should they have done? How do you see this?
Well, I think that there's a big difference between the practice in Canada and in the rest of the world, and that is that in the Netherlands, for example, which up until recently was the number one percentage of people who died by medical assistance in dying, in Canada, Well, in some parts of Canada, which are higher than others, in Quebec, where I come from, and in Vancouver Island out west, 1 in 15 people who die by due to injection from a doctor. And the requirements are generally throughout the world that death as a treatment is a last resort.
Right.
That if there are other treatments to alleviate the person's suffering, the person shouldn't be able to obtain from the state a way of killing himself in assisted suicide or have his life ended by a physician with other forms of medical assistance in dying, euthanasia. If there were some treatment, potential treatment that is not tried. So in the Netherlands, about 40-something% of all requests are refused because the doctors say, look, you're feeling life is worthless, but you don't seem really depressed. You've been taking some chemotherapy, which has a side effect in depression. Maybe we've got to treat it. Or you're saying you don't want to die alone. Well, what if we can fix it so you don't die alone? Let's try to see if we can find someplace, a hospice situation or something where you would feel comfortable. And a lot of people also make requests because they have unrealistic fears. People who have Lou Gehrig's disease, amyotrophic lateral sclerosis, often fear they're going to die from suffocation, but the research shows that only 2% of people risk dying by suffocation, and physicians say this is almost completely preventable. So, but that's almost 50% of people want to die because they're afraid of something that is very low probability. But the Canadian law is different. The Canadian law says that the doctor must inform you of any alternatives. But if the patient says, I don't want those alternatives, I want to die, the doctor is obliged, if the person meets the requirements, to provide death for the person. And if the doctor is not personally willing to do it, the law requires them to refer the person to a doctor who would be willing to do it. And because of that, there is the access is much easier. The other thing is that the Netherlands, for example, has a very robust judiciary system to inquire after every death to make sure that everything was done to keep the person alive and in a quality sense. And totally against just life for the sake of life, but getting rid of the suffering of the person so life is enjoyable, and that everything was respected. In Canada, we have never prosecuted anyone or made a formal complaint that has been accepted for any physician in their practice ever. So all the doctors in Canada are perfect. Where in the Netherlands, where they've been doing this for over 20 years, the doctors, there's hundreds of doctors are getting slapped on the wrist for this, or even prosecuted sometimes because they're not, they might have let someone die who could have gone on living. So we have a very easy access. Also, people are confused, and we changed the name from euthanasia to medical assistance in dying. And there were some surveys where you asked people, are you in favor of legalizing euthanasia for someone who is terminally ill and having unbearable pain? And people were against it. But when you said, are you in favor of medical assistance in dying for people who are terminally ill and in unbearable pain, the majority of people, large proportion of people say sure. But medical assistance in dying, as we call it in Canada, is basically euthanasia. So this was a brilliant move on the people who wanted to legalize it. Now it is open to people who are not terminally ill, who are suffering. The government wanted to include people who have a mental illness without the report that the government commissioned to someone who was very favorable to this basically said no particular requirements, no requirement for psychiatric evaluation or anything else. The doctor wants to ask for, and that's up to them, but there's no need for any special requirements. It would be prejudicial to ask for something more from someone from a mental illness to a physical illness. The suffering is just as great. And they're true. The suffering can be just as great, but the problem with a mental illness is that we are incapable of making an accurate diagnosis.
Yeah.
If you look at the research again, you cannot find people agree and are accurate in their ability to determine which people with mental illness will be suffering 2 or 3 or 5 years down the road, and which people will be in remission, or which people will get treatment and be doing great. There's no way of predicting that. And if you cannot predict that, then that means that a lot of people would die who could have gone on having a meaningful life. Now, the government, at the last minute, for the second time, have prolonged or stayed, like a stay of execution, but have stayed the law, expanding it to people with mental illness until after the next election.
Yeah.
So it's a bit of a hot potato now, because there's been a few spectacular cases with people who
Brian,
appropriately.
That very term, medical assistance in dying, seems completely inappropriate for serious mental illness, because it does suggest medical assistance in dying for somebody who's dying anyway. For mental illness, they may feel like they're dying, or may feel like they're dead or wish they were dead, but they're not dying. And so there is this important disconnect and alarm that you're raising that we need to be listening closely to in the United States and other parts of the world, because we've already opened the door to physician-assisted suicide. Could this also be next for us? So, you've been writing about ethical issues for a while, and I wondered if there were other emerging ethical issues in suicide prevention that you wanted us to be aware of.
Well, I just wanted to mention, I think that the other big issue with people with disabilities, because there's probably an ethical difference between someone who's dying and you change the timing of their death.
Yeah.
Someone who has a physical disability or a degenerative disease, but who is not dying. They're nowhere near death. And they're
being tormented.
Yeah, a few cases in Canada. One man who was approved for MAID because he lost his adapted housing situation, and they were going to put him in a nursing home where he wouldn't have the freedom to move about and do his own thing. So he said he'd rather kill himself, and they granted him his request. And a news reporter got hold of this and publicized it, and people sent him money, and and he was able to get a place to live. But the United Nations actually sent a letter to the Canadian government from one of their commissions on disability and human rights, saying that there was an ableism, that is, that viewing people with disabilities as less meriting continuing their life, and the focus needs to be helping people first, and not giving medical assistance and dying in such an open and easy way. I just came out with a book. You said I could try to show it.
Please.
Here we go. Practical Ethics in Suicide. It's published by Cambridge University Press, and it's fairly cheap at Amazon. They're giving 20% off on it. It sells for $50, and you can probably get it for free shipping for $40. And we go through a whole bunch of different ethical issues, and ranging from the sorts of things that one deals with, like, do you trace a call and send an ambulance?
Right.
And in the U.S., we think, why not? Same in Canada. You got to save a life. And in the U.K., Samaritans have been for years having the position that it's your choice. I'm not going to trace your call and send an ambulance unless you let me know that you want the ambulance. And they feel that people who will not feel comfortable contacting them in desperate situations, if they fear that their call will be traced and they'll wind up in the ER, and they also feel that you have the right to suicide. And, if you push me on it, I will say, I have a right to kill myself. So does John and David. Those or anyone else. I mean, it's your decision. The problem is when I find out about it, because if I find out that someone is going to kill themselves or have their life ended prematurely by medical assistance in dying, even if they're terminally ill, I believe that this is probably a tragic situation, and that there's hope. And I will do whatever I can to build hope, and I'm not. And so, if you tell me you're thinking of dying, I'm going to do what I can to build hope. But push comes to shove, we all have to have that choice. We have that choice that we can make. But I mean, a lot of issues now concern the internet. Australia blocks access to sites that provide information or means to suicide or encourage people to suicide. However, the problem with this is that Australian law only works with people who are based in Australia. They can't prosecute someone in another country for doing something that's illegal in Australia over the internet. But and there's some controversy about this, because the same information that someone will provide over the internet about how to kill yourself is available in your library in the medical section. So, is there some freedom of access? So there's a lot of ethical issues. What we do in this book, which I wrote with the ethics and law professor David Weisstuck, is we try to show how our implicit or explicit ethical beliefs or biases influence how we behave in these ethical situations. How important is it to save a life compared to the quality of life?
Yeah.
Right.
Is it an absolute? Now in the U.S., with all the debates about abortion, you can see that there are very extreme positions on all of this. And then in situations like hospitalizing someone for their own protection,
Right.
And issues of accuracy, or type 1, type 2 errors, how certain do you have to know that this person is going to be at risk of killing himself? How reliable is your suicide risk assessment scale?
Right.
It's not 100% reliable. So it's okay to send how many people to the hospital who aren't really at imminent risk in order to save some others. Well, if I was that person being sent and I'm not at imminent risk, I'd be pretty upset about this.
Yeah.
But you know, there are a lot of issues about that, and in the future we'll have issues about uh, Chat GPT type generative
Yeah, of
therapists
course. Of course.
replacing the jobs of people on 988
Yep.
and coming off as much more warm. There was a study of a computer therapist. It wasn't on suicide prevention, and in the study, they compared randomly. It was online text exchange therapy, so you didn't hear the voice. It was just a narrative therapy, and they said to the people, you might get a computer, you might get a person, and the people still came out better than the computer, but the computers did really well. And that may change any day now.
It's
But
going to change, right?
they asked the people at the end, do you think that you had a person or a computer?
Yeah.
And more people thought the computer was a person and the person was the computer.
Yeah.
So it's
That's right.
good at this.
So,
Yeah.
Brian, this sounds like an amazing text that's going to get into some of these real heart issues. Let's go back with a little bit of an interactive segment around this issue of the ethical issues around physician-assisted suicide, now medical assistance in dying. The American Association of Suicidology put out a position paper that you referenced in an editorial that you wrote with a colleague. Peggy Batten, who's an advocate of a more extensive medical assistance in dying, led the development of that paper. I'm going to read just for a few statements, and just would like you to reflect more true than not, or not so much. And here's why. So here's a couple. In suicide, isolation and loneliness characterize the end, as opposed to intensified bonds with family and friends and increased support with medical assistance in dying. What do you think about that statement? More true, or not as much?
Well, I mean, that's a description of the process. It's not so much the statement that matters. It's really the justification for the practice, because and you know that AAS has rescinded that statement.
I didn't know that.
They have, and it's been about a year now. And Peggy Batten sent around a little note to the members of the committee and saying, have you changed your views of this and that? She was fighting that, but they took that statement down, and because it's a very biased, one-sided position, because it says that things like that, people who have mental health problems, it's a little crazy or deranged to think about suicide. Cognitively, you're not functioning. You might be drunk. That could be true in some instances, maybe a lot of instances. But in the case of assisted suicide, this is a rational, thought-out decision, and without ambivalence. And I think the biggest piece of data about ambivalence that one can look at is if you look at the number of people who have received a lethal prescription in the United States. I did this up until a year ago. And how many people used that lethal prescription?
Right.
You find that among the people who convinced two physicians that they were suffering intolerably from a degenerative illness and probably they were going to die soon, they had a terminal illness, and they got the medicine, over a third of them never took it. They kept it in case it gets really bad. So it became more of an insurance policy.
Yeah.
And this idea that this is like a switch. I decide I want to die.
Yeah.
And that's it. A rational decision. Yes,
Right.
no. Of course, there's a lot of ambivalence in decisions like that. And the fact that it's rational, That's pretty strange, because the requirement is that you're suffering.
Right.
Imagine that your hand is in a vice, and we're making it tighter, and you're suffering more and more each day. Are you going to suddenly get more and more rational, or can you be rational when you're suffering?
Yeah.
And the other thing which is important to me is that most human decisions, important decisions, are not rational. What was the most important decision that you made in your life, John and Dave? Was it, who you married, what career to take? Did you, add up your future spouse's good qualities against their negative qualities and make a rational decision? If this
the algorithm suggested I should marry my wife.
So, Brian, it's funny that you asked that, because what happened was a professor came to me and said, "Here's the research." And I interrupted them and said, "But here's what I'm going to do."
Yeah. And there we go.
So, Brian, look, it's this is great discussion, and really such thoughtful analysis of some very painful and hard topics. So we're going to make a transition into something lighter for a moment as we begin to wrap up the talk with you. And one of the things I did to think about what we would do at the end was look at famous people from Montreal. Brian, who are the couple of most famous people from Montreal that come to your mind?
Famous, like Celine Dion.
Celine Dion is one on my list.
Yeah, we have our local famous people. I'm sure if I was into hockey, I could rattle them off.
Yeah.
Wayne Gretzky,
of course. So the two others that came to mind: Leonard Cohen.
Leonard Cohen, absolutely.
Hallelujah. Celine Dion, of course, and William Shatner is from Montreal too.
Yes,
I'm going to say to infinity and beyond, John, but it's Space: The Final Frontier. So the way we're going to end today is I'm going to read some quotes that these either came from William Shatner, Captain Kirk, or they didn't. So I need you to, John, you and Brian, take a guess.
All right.
Quote number one from William Shatner, Captain Kirk, or not. Nobody could have survived that. Is that truly a quote from Captain Kirk, William Shatner, or not? Nobody could have survived that.
I'm going to have to guess. I would say true.
I would say true as well.
It is from the 1979 movie, Star Trek: The Motion Picture. The next one, I'm not interested in money. I just want to be wonderful. Did William Shatner or Captain Kirk say that?
I can't see it, but I can't see what episode he would have said that in.
John, what do you think?
I could see William Shatner saying that. I don't know about Captain Kirk.
Well, this is a big difference. Is it William Shatner or Captain Kirk?
Yeah.
Are we talking Star Trek, or are we?
Yeah.
It could be either one. In this case, it was neither. That quote was attributed to Marilyn Monroe.
I wish he had said it.
I'm going to skip Beam Me Up, Scotty. You guys know that.
Yes.
Well, actually, the truth is that it's widely associated with Star Trek, but Captain Kirk never said it. Here's another one. Did William Shatner say this? Get a life. It's just a TV show.
No.
Brian?
It wouldn't be very nice to his fans, but
he did say it in a famous Saturday Night Live sketch where he parodied his fan base.
Okay.
Okay, here's two more. I'm not afraid of dying. I just don't want to be there when it happens.
Oh, that sounds like something William Shatner would say.
Brian?
I'm not sure he would say it. I would say Mel Brooks or something.
That quote is attributed to Woody Allen. And the last one. I'm so filled with emotion about what just happened. Was that William Shatner?
No.
Well, he just went up in space. So
he went up in space, John. Before he went up in space, I would have said he never said that. Did he say it after he went up in space, John?
Yeah.
He did. He came back from Blue Origin's New Shepard rocket, and he called it the most profound experience he could imagine. He said what hit him was the enormity and suddenness of life and death.
Yep.
What a great conversation has been with Brian Mishara, but it brings us to our incredibly true tales of behavioral health link segment, John. You believe it or not, this is a true story, and it
absolutely
shows the impact. John, the year was, oh my God, I think it was 2012, somewhere in that range. And I was in the crisis call center, it's Contact, in Belfast, Northern Ireland. Brian, have you ever been to Belfast to the call center?
I have not.
They have a sister site in Londonderry, or they did at the time. It was operated by Fergus Comiskey. And I walked over to a bulletin board, which I took a picture of here, John. And on the bulletin board, they had, first of all, I was really impressed by it was a technologically sophisticated and funded site, but really focused on the kind of care and engagement that Brian's been referencing. But on the bulletin board were the suicide risk assessment standards and the protocol for engaging callers at imminent risk. And Brian, it really stunned me, the reach that science can have. And it really did start with work that you and John Califat and Maddie Gould did for beginning to give us an insight into what's actually happening, the acuity of callers, the variability of practice, the effectiveness of self-disclosure and engagement and care. I remember, John, at the time, our organization, Behavioral Health Link, was highly funded into, we used a lot of resource for QPR, and came out of some of that research feeling like ASSIST gave us a better focus on that human contact and that helping the person in the moment, and began to retool our approaches based upon the work that, again, Brian was so influential in. So, believe it or not, John, you were there, buddy.
Yeah, actually, I don't know if I was there, David. Was I?
You were there throughout the
process. You know
process.
better than I do.
You should have been there in Belfast,
I
John.
should have been.
Yeah. But, John, that brings us to is there some plain truth that you've got for us today?
There absolutely is. And it's in celebration of Brian being here. You know, in 2004, when I first began administering the Lifeline network, David, I had not really been exposed to the world of suicide and crisis hotlines beyond LifeNet, the crisis center that I was managing in New York City. So at LifeNet, most of our 50-odd staff were master's level clinicians. And I began to fully appreciate the other ways of operating hotlines only when I attended my first AES conference in April of 2005, when I met the other hotline directors from our Lifeline network. These directors led hotlines that relied heavily on volunteers, radically different than LifeNet's professionally staffed model back home. Their leadership and culture were steeped in compassion and dedication to suicide prevention, and it differed a whole lot from the community mental health services that I was familiar with. At LifeNet, our training focused primarily on behavioral health assessment and referral protocols, with minimal emphasis on suicide prevention. Our hiring practices were influenced by two key assumptions. First, hire people with a mental health related master's degree because they would require less training for hotline work. So we thought. Second, master's level clinicians would also be more capable of assessing and referring people to community behavioral health services because that's where the real care happened. The underlying belief was that hotlines were mere conduits to mental health services, and the more our staff knew about those services, the better they could perform their job.
Right.
Over the years, we've gained invaluable insights from crisis hotline evaluations. Brian has performed extensive research trainings and evaluations at hotlines worldwide, and one of the many things his work has shown is just what he was talking about earlier, that volunteers often outperform paid staff, particularly those with advanced mental health degrees. Volunteers are more likely to conduct risk assessments, exhibit empathy and respect of callers, and achieve higher caller outcome ratings. And from a historical perspective, suicide and crisis hotlines have been built on the backs of volunteers. And that's essentially what Brian was noting earlier. And the pioneering suicide prevention researcher Lewis Dublin described the use of non-professionals in 1969 this way as the single most important discovery in the 50-year history of the suicide prevention movement. But now, with the advent of 988, the use of volunteers and crisis hotlines may be fading into the history books. Until recently, a mix of volunteers and paid staff at crisis centers remained common. Just in 2018, about 55% of Lifeline Network centers reported they still had a mix of volunteers and paid staff. However, now that 988 has brought greater funding to centers to hire and train staff to answer calls, state and county funders have the expectation that staff will be available to answer at least 90% of calls in less than 30 seconds. And that means we got to have more paid staff. For example, BHL is providing our software and consultation to the statewide Idaho Crisis and Suicide Hotline, where volunteers answered most of their calls until 2021. But in preparation for 988's launch in 2022, Idaho funded the volunteer center's transition towards 100% fully paid staff in just 1 year. And the rationale is that paid staff offer more consistent availability for overnights and weekend shifts. And we got to have reliable staff on hand to be able to meet the demand for rapid response times for callers in crisis. Now, even though Brian showed volunteers often perform better, having paid staff doesn't mean you have to sacrifice quality. When Brian did an evaluation of 5 Quebec crisis hotlines about 10 years ago, I know you remember this, Brian, you didn't find any differences in caller outcomes between paid staff and volunteers. And comparing this with prior research findings, Brian, you were noting that U.S. hotlines typically required their paid counselors to have an advanced degree in mental health, such as a master's degree, which was not required of your staff in Quebec. This finding suggests that graduate-level training in mental health appears to be a potential hindrance to crisis hotline work. Meanwhile, a number of states right now are requiring paid master's-level clinicians to answer calls. Now, it's disturbingly counterintuitive as Brian's findings may seem. They certainly remind us that crisis care is a different type of mental health care that requires distinctly different training than, say, psychotherapy. One could say that crisis care training should be to mental health credentialing as CPR training is to medical work. Currently, all medical doctors have got to be certified in CPR, but crisis care training and certification is neither common nor required for advanced degrees in mental health work. What research has also shown us is that experience is the greatest teacher for crisis work, whether the person is paid or volunteer. Crisis care specific training helps, but practice makes perfect, so to speak. So how are we going to leverage that experience if we can't keep our workers? We've got to find ways to keep our workers. So how do we do that? With competitive wages? Yeah, that helps. But also finding people who feel called to this work and giving them a career pathway is central. People like me have stuck with this for 35 years because I love it. I found a career pathway that I had no idea existed in graduate school. Career pathways need to be built into crisis hotline funding and program design, and psychology and social work academia needs to include crisis and suicide prevention in its coursework, field placements, and credentialing. If volunteers are to become scarce on crisis hotlines, we must at least hold on to the lessons they've taught us, David. Crisis hotline workers don't need mental health degrees so much as they need to have empathy, compassion, a calling for the work, a competitive wage, and a career path bolstered by supervisory support that helps them build on their experience. And for people with advanced mental health degrees, it wouldn't hurt to have them all certified in crisis care, the way medical doctors are with CPR. If we can make these things happen, maybe 20 years from now, Lewis Dublin's great-grandkid could pronounce that non-mental health trained crisis workers are the single most important discovery for suicide prevention in the 21st century. That's the plain truth, David.
John and Brian, that's a real lifeline. A huge thanks to you today, our guest, Dr. Brian Mishara, and for the work you've done and the impact it's had on all of us. And for all of you out there, be sure to join us next week when our guest will be Dr. Eric Rothfler-Yuan, author of a key paper around decoupling police from crisis response. So thanks for letting us draw you in another week. Come back next time as we continue to navigate the currents of crisis and care. Until then, remember, every call, every life Every story matters. Stay connected, stay supportive, and we'll see you on the next episode of Lifelines.
Thank you all.
Okay. Thank you, John. Thank you, David. It was a pleasure.
Brian.